Assalamu alaikum. This is Ahmad.Madkour. Here we will show an edited video for oil procedure to a patient with type 2 achalasia. Usually in type 2 achalasia, we do standard tunnel 10 centimeter above the cardia. We start injection to the right or the left of the spine at 5 or 7 o'clock, and we do dynamic injection. Once we have a nice submucosal lifting, we use the up dial of the scope to have the needle tangential and have a good feeling of the submucosa. Here we are using Fujifilm 760R gastroscope. The outer diameter is 9.2, the working channel is 2.8, and we are using ST hood, which is conical shape, it also from Fuji. After the injection, we avoid to give air or do suction to keep the submucosal fluid in place and decrease the absorption of the submucosal fluid. Here we will use flash knife 3 millimeter and to do the mucosal incision. We do the first cut, then we can inject through the knife more fluid, as you can see. Then we push the scope in while moving the needle up to do the mucosal incision. Then we start to do trimming for the edge. We use for mucosal incision Endocut I, effect 2, duration 2, interval 2. Here we're using RB Bio D300. Then we do the trimming of the edge using spray coag. Here we use spray coag, effect 2, 40 watt. We can see some mild oozing of blood. Usually this is minor with a mucosal incision. After we do trimming, we try to go to some mucosal space. As we do a nice trimming, we can easily move to the submucosal space. Then we start to do injection again using the same knife, and then start to do submucosal tunneling. You can see we use here spray coag. Spray coag work very effective with flash knife. You didn't need to touch, you can do untouchable, as you can see. And we try to dilate the tunnel to have a nice wide tunnel. We cut the submucosa, which is stained with the blue color, as you can see. We be very close to the muscle. It's healthy to have this superficial muscle injury. We have no problem in this, to keep the submucosa, to keep the mucosa intact. Once we progress, you can see here a red structure. It looks to be a vessel. So we try to isolate this vessel. So we dissect some mucosa to the right and to the left. Then we decide to do. Here we decide to coagulate the vessel using the knife. We switch to soft coagulation. Soft coagulation, effect 4, 80 watt. And you can see the vessel turned white. Then we switch back to spray coag, and then we can cut the vessel without the need to use the coag rasper. We continue dissection towards the cardia. Usually we cut in the blue color, which is the submucosa stained with our injection fluids, which is methylene blue and saline. We don't use adrenaline while doing tunneling. Here we can see another vessel. Again, we isolate. We think we can cut this with the knife also, but it was small, so we cut directly with spray coag. Actually, spray coag is very strong current, and flash knife works very well with spray coag. You can notice that we keep going back and in to make sure we are in the right direction. We should be perpendicular to the circular muscle, not to lose our way inside the tunnel. Here, the esophagus is not dilated, so we don't have this problem, but if you do this procedure in a sigmoid esophagus, you may lose your way if you don't keep doing this. Usually, move out and move in, be sure you are in the right direction, and do repeated injection, as you can see. So this is the right direction, and we continue dissection again. Again, we can see a vessel here. So we isolate the vessel, check the size of the vessel, then decide the best way to coagulate. If we directly cut with a knife, if we switch it to soft coag or to coag rasper, you can see how strong is spray coag with flash knife here. Although it's not small vessel, but again we can cut directly with spray coag with flash knife, even we don't switch to soft coag. And we continue dissection towards the cardia while we are parallel to the muscle. Avoid being very close to the mucosa and perpendicular to circular muscle. And very important to keep a wide tunnel. Keeping a wide tunnel makes the whole procedure more easy, decrease the gas-related complication, and make it more easy to go through the tight cardia. If you have a narrow tunnel, it will be more and more difficult to go through the cardia. Again, we do some stretch to the submucosa using the cap, and we do repeated injection through the knife, and again we continue tunneling through cutting the submucosa. Here we start to be close to the cardia. You can see it's become a little bit narrow, and step by step we can go through the cardia following the same rules. You start to see now on the mucosal side, this is spindle veins. You can see on the upper and lower esophageal sphincter. Again, we do injection. And continue dissection. Here we think this is a vessel. On the gastric side or near the cardia, we be more cautious. So we change our setting to soft coag to coagulate this vessel. As you can see, we boil right and left before we cut again using the spray coag. Now, after coagulation, we cut using the spray coag and move downward again toward the stomach. Usually it's very important to do recurrent injection. Usually try to see this nice blue color so you are safe and you can cut the submucosa without causing mucosal injury. You can see here while we try to do some dissection, we have bleeding. At this point, we can see it's an active spurting bleeding. It's not so severe, but it's better to switch to coag grasper. So we do a mechanical compression using the cap, as you can see. We avoid suction, unnecessary suction, to avoid increase the bleeding. We just flush with the irrigation pump. So we can see down here the bleeding. We switch to coag grasper, and we use a soft coagulation current. We use soft coag, effect 4, 80 watt with RB Vio 300D. If we use RB Vio 3, we use soft coag effect 6.5. So it decreases, but it's better to grasp again. And again, we do the coagulation until we see this bubbling. And while doing the coagulation, we pull back the grasper so we avoid transmitted thermal injury to the mucosa. Again, we grasp, coagulate, pull back. This coag grasper from Alton. This is Alton coag grasper. Now it looks fine. So we will switch back to the flash knife. You can see it's became more wide now because I think now we move to the gastric side, but we need to move for more centimeters, 3 to 4 centimeters. But you can see it's became more wide, and we will see more anatomical landmarks to be sure we are in the gastric side now. Again, we do injection. So we expand submucosa, as you can see here. Inject again here. Then we start to have the needle out and do dissection. This needle is 3 millimeter length, so it's maybe more suitable for tunneling than shorter knives. Here we give a long press because we have a bleeding here, so we wanted to make sure no more remnant of vessels, so we give the current in a stronger way so we can avoid bleeding anymore, and continue dissecting toward the stomach. Should be careful not to go intramuscular, because when we move from the esophagus to the stomach, we have the hub of the cardia. So sometimes we can see the muscle in front of us. So should be always oriented with the anatomy. So you avoid to go inside the muscle. You avoid to go intramuscular. Usually your plan is the submucosa. Now you can see how wide we are. Now it's very wide. You can move to the right and to the left because this is the stomach, and you can see the muscle here started to be oblique. It's not circular like it was in the esophagus. It started to be oblique, and when we reach this point, we start to direct our tunnel to the right. So we avoid cutting sling fibers, which will be on the left. Sling fibers have a very important anti-reflux mechanism. So when we do our myotomy, we should avoid to cut the sling fibers. So when we move to the stomach, we move to the right. So we go with the tunnel in the stomach, then we direct our tunnel little bit to the right. Here we have some vessels, so we switch to soft coag and start to coagulate. It's like a network. So we do coagulation before we continue for dissection. You can see down on the muscle there is like a red spot. This red spot is a pericydial vessel, and again this is one of the sure sign we are in the gastric side. You can see now, you can see on the muscle like an end points vessels, like white dots vessels. Here we continue dissecting. In the stomach, we should be more careful regarding the bleeding, because the bleeding here usually more severe than the esophagus, and usually we need the coagrasper not only the knife. In the esophagus we don't use the coagrasper anytime, usually the knife was enough, but in the gastric side it's different. You can see now we started to be totally oriented to the right to avoid cutting sling fibers as we mentioned before. So I believe we can tunnel in the gastric side even more than we need. We can tunnel for 3 to 4 centimeters to make sure we go enough in the gastric side. And when we are going to do the myotomy, we don't need to cut all the tongue. So we just cut 2 to 3 centimeters of the gastric muscle. If we tunnel 4 to 5, no problem. So you can tunnel more and cut less. But you should be 100% sure you move enough in the gastric side and have enough gastric myotomy. You can see here we have these network vessels. It's related to the mucosa. It's not a penetrating vessel. So we just isolate the submucosa with the vessel and let it retract towards the mucosa. We don't need to cut as long as it didn't came out from the muscle. You can see here it's a nice dissection plan, and we totally isolate these vessels. And you can see down there is the oblique muscle. This is the oblique muscle of the stomach, and we tunnel enough to make sure we have a sufficient amount. After that, we inject in some mucosa and go out to check what we did. I think this is the level of the cardia, and this is the rest of our tunnel. And we go out. You can see the cardia became lax even before doing the myotomy, we can do retroflexion to check blue sign, but actually this is not an accurate sign. The most accurate evidence is to see the anatomical landmark we talk about, and you can see here the blue sign. And we do suction for some fluids in the stomach. Some fluids and gases to decrease pressure inside the abdomen, and we move back to our tongue. And now we will start to do the myotomy. We use the same coagulation current. We use spray coag to do the myotomy, and we try to do the first cut using coagulation current. Yeah, it's better to do selective myotomy followed by full thickness myotomy, 3 centimeter above the cardia, but it's not a big issue if we do a full thickness myotomy from the start. So we here have a full thickness in the beginning, then we move to the plan of selective myotomy. Here you can see this is longitudinal muscle, and we cut the circular muscle. We hook the fibers, we push the scope in, and let the up dial up, so we let the knife cut to up, and we continue to do full thickness myotomy to do in a faster way, as you can see. Here, this is the plan again. We push the scope and let the needle up and let the current cut. We usually use coagulation current to do this. And here we are approaching the cardia, but we should go back not to leave any remnant muscle, so to take all the muscle and we cut towards the cardia. Here we are cutting the sphincter and we are moving to the gastric side. Again, this is the plan, and we cut. When we go to the gastric side, you start to see the muscle is more thin. We cut again toward the stomach. We make sure we don't have any remnant muscle fibers, so we cut these fibers also and take our plan. And this is the point we talk about. When we move to the gastric side, we orient it to the right, let our myotomy moving to the right to keep sling fibers intact to avoid high incidence of reflux after POEM procedures, because it have a very, very important anti-reflux mechanism. You can see here, down there, we started to see this gray color. This gray color is for peritoneum, and this is sure sign we have moved to the gastric side, and we continue for 2 to 3 centimeter myotomy in the gastric side to avoid any recurrence, but we shouldn't go more than this to avoid a reflux. So we can see here, we can see a peritoneal fat. So again, this one more sure sign we are in the right way and we go enough in the gastric side. We don't need to cut to the end of the tunnel. So if we convenient and we are sure we do a sufficient gastric myotomy, we don't need to cut all the way down. And this is the peritoneal fat. This is a very sure sign. We go to the gastric side, and here is the adventitia of the esophagus. It's different from the peritoneum, which we see. Now this is the adventitia. but down there was the peritoneum, and we go out and we check again the mucosa, that we don't have any mucosal injury after the myotomy. We avoid to do retroflexion after myotomy. We just take out some air from the stomach of the patient. Then we go out to do the last step, which is closure of the incision. Before this, we move again to the tunnel. To check everything is okay. So everything is okay. We don't need to do any hemostasis for the edges of the muscle here. And now we move to closure of the incision using hemoclips. Usually first clip is the most important clip. Here we use a microtech clip. The edge of the clip should be distal to the incision. So if we are not convenient with the position, no problem, to open again and readjust our clip. Now this is perfect. Then we close and file. Once you have your first clip in the right position, other clips is very easy to apply. And you usually check that both sides are well grasped using the two edges of the mucosal incision by the two arms of the hemoclip. And now we place the second hemoclip. We close, check the position is good, then we fire. This step is simple but very important. If we do all this good work and we don't clip the incision in the right way, we may have a complication, we may have a leak, we have an infection. So we should have enough time to close our incision in the right way. Make sure both edges are well grasped using the hemoclip, so we avoid any delayed complication. So we place the third clip. Again, we grasp, check the position is good. It was not tightly closed, so we reopen and will do a reposition for the clip. We close and fire. And again check that both edges are grasped in the right way. Now we try to place the last clip. The patient has some tachycardia now. He is prepared to be awoke, so we don't want to interrupt this. And we place the fourth hem clips. And this was the whole procedure. I hope it was helpful. Thank you.